Hello, my name is Dr. John DeWitt, and I am Professor of Medicine and the Director of Endoscopic Ultrasound at Indiana University Health Medical Center in Indianapolis, Indiana. And on behalf of my co-authors, I would like to thank you for watching this video for the GIE author interview series for our paper, which was recently accepted. The paper is entitled Comparison of Functional Lumen Imaging Probe and High-Resolution Manometry to Assess Response After Peroral Endoscopic Myotomy. Peroral endoscopic myotomy, or POEM, is currently the treatment of choice for achalasia and other esophageal motility disorders when applicable. Outcomes following treatment can be assessed several ways, including the patient-reported Eckert score, high-resolution manometry, and most recently, the functional lumen imaging probe. Manometry is a transnasal catheter which is placed in an unsedated patient, and because of this is often very uncomfortable. Functional lumen imaging probe, shown here, is a device that is placed transorally and uses impedance planimetry to measure changes in luminal cross-sectional area and pressure in response to controlled balloon distension at different volumes. The current measure, called the distensibility index, is the most useful metric from this procedure to measure distensibility or stiffness of the lower esophageal sphincter. FLIP is performed during upper endoscopy and therefore during sedation, but the test has not been compared to high-resolution manometry to assess clinical response after POEM. Therefore, this study was performed to compare these, and we hypothesized that normalized post-procedure metrics by the FLIP procedure and the IRP, or the integrated relaxation pressure measured by manometry, would be equivalent to predict clinical response using the Eckert score as a gold standard following POEM for achalasia. This was a single-center retrospective study of prospectively collected data on patients who underwent POEM for treatment-naive achalasia and at least 6 months follow-up. At baseline, all patients underwent calculation of an Eckert score, high-resolution manometry, and functional lumen imaging probe of the esophagogastric junction. There were 3 metrics that were used to determine normality, or a normalized value after POEM. These included a EGJ distensibility index over 2.8, a maximum diameter of the EG junction of over 14 millimeters, or a normal integrated relaxation pressure of less than 15 millimeters of mercury. All of these 3 studies were compared to a normal clinical response, which was defined as an Eckert score less than or equal to 3. During the study period, there were 207 POEMs performed, and 120 were excluded for follow-up less than 6 months, previous therapy before POEM. All studies were not performed at follow-up or refusal to return for follow-up testing. This left 87 patients with treatment-naive achalasia who comprised of the primary study population. This slide illustrates Table 1, which shows the demographics, baseline features, and results of POEM for the 87 treatment-naive patients with achalasia. As you can see, there's type 1 achalasia in 10 patients, type 2 in 68, and type 3 in 9. The mean age was 51, mean Eckert score was 8.1, and EGJ distensibility indices at all 4 balloon distensions showed a non-compliant lower esophageal sphincter. The mean myotomy length was 9.7 centimeters. The circles illustrate the 4 significant p-values when comparing the type 1, type 2, and type 3 patients. The mean LES length was lower in the type 1 patients. The mean Eckert score was lower in the type 3 patients. The mean width of the esophagus was smaller in the type 3 patients, and as expected, the mean myotomy length was longer in type 3 patients. This slide illustrates the clinical response by all of the 4 measured clinical metrics for the 87 patients, and also stratified by the type of motility disorder. The overall response by Eckert score was 97.7%, by integrated relaxation pressure was 86.2%, by EGJ diameter was 76%, and by distensibility indices was 92%. These values were similar for all 3 types of achalasia. This slide illustrates a comparison of the sensitivities for a normal manometry IRP and normal diameter and EGJ-DI by flip measurement to predict a clinical response by Eckert score for all 87 patients. A normal IRP, diameter, and distensibility index had a sensitivity of 87%, 75%, and 92% to predict clinical response. The p-value comparing the sensitivity for a normal IRP was no different for a diameter or an EGJ-DI. However, the sensitivity of a normalized EGJ-DI was significantly better than a sensitivity by the maximal diameter to predict clinical response with a significant p-value of 0.001. The primary study population for this paper were treatment-naive patients with achalasia who underwent POEM. If we include the 25 patients we excluded for this original population who had previous treatment, we end up with 112 patients, and overall response by Eckert score, IRP, diameter, and distensibility index was 97%, 85%, 76%, and 92% respectively. When comparing those without previous treatment to those with previous treatment, these values were not significantly different for all four measured metrics. This slide illustrates the comparison of a normal IRP and normal flip metrics to predict clinical response in patients who have had previous treatment and in those who have not had previous treatment. And as you can see, there is no difference in the sensitivity of either a normal IRP, diameter, or distensibility index to predict clinical response in patients without previous treatment or with previous treatment. From the study, we concluded that a normal IRP by manometry and a normal maximum EGJ diameter and distensibility index 6 to 12 months after POEM all showed good to excellent sensitivity to predict clinical response by Eckert score in both treated and untreated achalasia patients. Therefore, the use of flip may be an acceptable alternative to manometry to objectively measure the LES pressure after POEM in short-term follow-up after these patients. Thank you.